we've discussed, previous speakers have spoken about arthroplasty and in elderly patients, and there is a tsunami, silver tsunami, as Dr. Malhotra said. But there is a tsunami of TKRs happening in the country, and a lot of these patients will probably need revision because they are being done for various reasons. Many total knee arthroplasty patients are less happy than we realize. Surgeons have traditionally assessed these patients' satisfaction subjectively or using unvalidated measuring tools. They always say trust the surgeon more than trust the patient. If we look at the measuring outcomes, historically, we used revision rate as a surrogate of success rate. And there is plenty of evidence that this is not reflective of patient satisfaction. The literature says anywhere between 10 to 20% of TKR patients are not satisfied. And the newer study says as high as 70% of patients are not meeting the expectations the surgeons have set them after a total knee arthroplasty. Born in a study of almost 1,700 patients, confirmed that 19% were not satisfied with the outcome. Satisfaction rate of pain relief was only 70 to 86 and function from 70 to 84. Weil also said that there is no difference in the implant types, whether we use one implant or the other, but only 66% patients were very satisfied with pain relief, 52% came to normal activity, and only 44% in his study were able to perform leisure activity. A significant number of patients are not satisfied with the outcome, despite clinical findings and X-ray, which looks fine to the surgeons. You look at the X-ray and you think, that's perfect, I did a good job. But you have an unhappy patient at the end of it who's not happy because he wasn't expecting the same result. We know from Evelyn that knees do worse than hips. When he did his study on 10 years hip and knee patients, 440 cases, he had very happy percentage of 54% of hips compared to 4% of knees. Conversely, the number of never happy knees was higher, 7% compared to 1% in hips. Despite advances in instrumentation, implants, and techniques, patients and surgeons don't always agree on the quality of life improvement and how happy they are. And the forgotten joint score is evidence of that the knees don't do as well as the hips. As one of my trainers said while I was training, that you only have to go 1 to 2 degrees wrong for a knee to be unhappy. And for a hip to be unhappy, you have to be 10 to 15 degrees wrong for a hip to be unhappy. The data we tend to use when we're consenting patients or with their 92 to 98% results, 10-year survivorship on this data, on various implants which we use, or we start using the old data, but sell the patients unvalidated implants or local implants, which has no survivorship data available in any of the joint registries. And objective outcomes in terms of range of movement, stability, or the X-rays. So based on that, I would start the talk of unhappy patients. The most important fundamental question is figuring out if there is something to fix in this patient. You want to make sure, is there something wrong in this patient? So take a detailed history, physical examination, and tests to close the deal or confirm the diagnosis. Majority of the time, from the history and the physical examination, you will find out what the problem is and what is wrong with the patient. And figuring out if there is something to fix, it can be infection, which is can be anywhere between 0.05% to 1 to 2%, depends on which joint registry data you use or which papers you pick up. Malalignment, which can be very difficult to pick up if there is subtle malalignment, especially malrotations. Overstuffing, if you've oversized the knee, that can cause patella loading, which can cause painful knees, especially when they are going upstairs or standing from a sitting position. Or poor sizing, which can be because the instrumentations which are not up to the mark, or they have been used so many times that you can't size them properly. And you can have misbalance of flexion extension mismatch. They can be abnormal joint line or slope. You can have anterior slope, posterior slope, which can cause instability in the knees, and patients will feel not happy. And most importantly, the psychology of the patients. If you haven't consented the patients correctly, and if you haven't got the patient's expectations up to the mark, then the patient won't be happy. The most important bit is to make sure that's a pain relieving procedure and the patient understands that. They're not going to run a marathon or go and start doing things which they were not doing before. It's a pain relieving procedure. So history, what was the indication of total knee arthroplasty? Was it a routine osteoarthritis, or they had multiple previous operations with associated soft tissue trauma? They can have scars, nerve injury may be the source of pain because they had previous arthroscopies, osteotomies, fractures, or previous joint replacements. They can have perioperative problems. They can have perioperative wound problems, which can cause low-grade infection, which is ongoing, or they have a UTI, pneumonia, or other infections post-operatively, or just before this symptom started. And it might be a low virulence infection causing pain and stiffness. You need to ask in the history, was there ever a happy period after a total knee arthroplasty? Because if the knee was never right, it could be a technical issue. There might be a flexion extension mismatch, or there can be patella maltracking, or there can be tibiofemoral instability, which is the causing of pain. Or it can be the knee was perfect to start with, and the symptoms developed over time. Then it can be a septic or aseptic implant loosening, indolent infection, late hemogeneous infection, or development of a referred pain, that they might have hip arthritis or spine stenosis or pain radiating from the back. Is the pain different from the pre-op pain, or is it the same pain? If it's the same pain, then it might be the surgeon got a wrong diagnosis. It's a referred pain from the hip and we've done a knee replacement because the knee showed arthritis. Is there an associated stiffness? Was there ever a good range of movement? Are there situations which are particularly painful, like standing from a sitting position, or sleeping at night when the patients have pain, or coming downhill? That can tell you what's going on with the patient. If the patient pain is different from the pre-op, unlikely that it's a poorly done total knee arthroplasty will precisely replicate the same pain. If the pain is different, that means it's from the arthroplasty. If the pain is the same, look for an alternative source. It can be a hip, it can be a spine. If you look at the literature, there's loads of papers discussing these issue. Mr. Seong from South Korea analyzed 438 total knee arthroplasty and predicted 7.5% patients were dissatisfied, but only half of dissatisfied patients were due to total knee arthroplasty. So it is important to inquire and examine the ipsilateral spine and the hip. Ipsilateral hip and the spine, sorry. Is there associated stiffness? Was there ever range of movement good? So never able to achieve a reasonable range of movement may indicate a surgical or technical issue, overstuffing, malrotation, inappropriate sizing, abnormal joint line, or slope. Loss of range of movement, which was there initially, can't be related to how the implants were put on. Then it can be infection, CRPS, or arthrofibrosis. Are there any particular situations where the knee has been particularly painful? Anterior knee pain, stairs, rising from a chair is mainly patellofemoral pain. Diffuse pain, difficulty with stairs in mid-flexion instability. Sudden giving away is quads weakness or ligamentous deficiency. Startup pain, loss of fixation. Constant pain worse at 9, suggestive of infection. When we examine for varus or valgus thrust, suggestive of poor balanced knees, or if there might be a possible ligamentous insufficiency when you're assessing these patients. And you examine the hip to see if there is stiffness in the hip, or the spine for arthritic spine or spinal stenosis, or look at the MRI if there is a disc prolapse which is causing referred pain. When you're examining, you look for the effusion to see if there is something which is causing joint irritation. This can be infection, it can be instability. Look for the quadriceps wasting. Look for subtle mid-flexion instability. I normally get the patient sit on a couch, raise the couch as high as possible, and then try to pull longitudinally the leg down in flexion to see if there is opening of the joint line. This suggests some instability in flexion. Also look for the AP movement. Sometimes I take the patients to theater while I'm aspirating the knee to do an EUA to check for instability, which it might not be obvious when you're examining the knee. Sometimes it can be very obvious instability, like gross instability like this, or it can be subtle. This patient didn't have a weight-bearing X-ray, and when you do the weight-bearing X-ray, it opened up completely on the lateral side. Put the knee through the range of movement, careful assess for patellar tracking, clicking, tilting. Look for lack of extension. Fixed flexion deformity can cause quads to work a lot of time, causing buckling of the knee while walking. Look for the angle of foot progression. If the foot is pointing outwards, it can be a sign of internal rotation of the components causing externally rotated foot. CRPS is rare, but we do see occasionally patients with total knee arthroplasty having shiny skin, diffuse tenderness. Middle-aged females, majority of the time, have swelling, edema, and they have trophic changes with wasting of the skin, thickening and thinning of the nails, and brittle nails in the foot. Get a full-length radiographs. Get an AP, lateral, and skyline to see if there is any obvious malalignment, malpositioning. If there are radiolucent lines, look at the X-rays over a period of time to see if there is any changes occurring over a period of time. Look for asymmetric polywear and stress view for instability. Skyline views, it's a screen. It does not guarantee good patellar tracking if it's well positioned, but definitely indicates something is wrong if it's tilted, subluxed, or dislocated. Then do the investigations, ESR, CRP, do the joint aspiration. At the same time, I do inject the knees with local anesthetic to see if that relieves the pain. If they relieves the pain, then we know that the problem is in the knee, and we need to look harder if we can't find the cause of the pain. Technician scans, rarely we use it if we can't find any other reason to do it, but the workhorse of investigation in the mystery knee situation is getting a CT scan. So painful knee, which was never right, with a poor range of movement, X-rays unremarkable, no evidence in hip spine pathology. Get a CT scan to look for the implant position. And it is important that either you or your radiologist is trained how to check for internal rotation of the implants or external rotation or malrotation of the implants, both tibial component as well as the femoral component. Remember, TKR is a resurfacing operation that depends greatly on the soft tissue envelope. Malpositioning of component adversely affects the balance and tension of the ligaments. This can lead to abnormal kinematic function, which can result in stiffness, instability, early loosening, and more importantly, an unhappy patient. I summarize, when to revise when we have a clear mechanical problem identified, occasional patient with good psychological profile, capacity to rehabilitate even without clear pathology identified. That is becoming less and less when you investigate harder. We do our MDTs where we meet every week and discuss all our revision arthroplasty patients with 15 other revision surgeons in our network. When not to revise, when there is clinical examination normal, no pathology after full workup, and the psychological profile of the patient does not fit. High-risk patient with poor skin, medical status, sometimes they are, especially if there's a low-grade infection with a high-risk patient, we can leave them on a long-term antibiotics. I thank you.